He's joined us, so we should be starting within few seconds. Uh-huh. Okay, I'm just waiting for. Okay, yes, we should be starting any second now. Okay, I think we are live now. Hi, Dr. Sohail, you can hear me?
Yes, I can.
Okay, assalamu alaikum, and thank you so much for joining us, Dr. Sohail, today.
Assalamu alaikum. Thank you, Ma.
Walaikum salam. So, hi everyone, this is Maha Khan and I'm live from Islamabad, and today we are joined by Dr. Sohail Sheikh. He's the director of Rainbow Eating Disorder Center in Lahore, and he's also, he has a practice in New Zealand as well as in Pakistan with background in psychiatry and eating disorders. So Dr. Sohail, before I ask you to introduce yourself, I really want to say thank you so much for everything you have done for us and every time you have stepped in to help us. So from all of us, thank you so much. So if you could please just tell us about yourself.
Sure. Thank you for kind word. I started my with training in psychiatry back in US over about 30 years ago. And then I worked in US for about 12 years and then moved to New Zealand. And then somewhere a few years down the road, we opened up our first eating disorder center in Lahore, Pakistan. Since then, we have been training people in this area as well as seeing patients and trying to help across different forums. So that's the introduction of me.
Thank you so much, Dr. Sohail. This is brilliant. And so if you could, the people who don't know about the eating disorders, if you could just tell them, what eating disorders are and where does this illness comes from?
Okay. So, yeah, it's a short question, but with a long answer. I'll try my best.
Yes.
So, eating disorder history goes way back, and even after the, but it got a bit more attention after the Second World War, when we found that there were people who were, especially initially it were men that where we saw a lot of anorexia, and many of them, they were coming from the Nazi camps. And later on, we found that as there is more evolution of the TV culture and more exposure to body images, it became more and more common among girls, the young girls. So that's how the eating disorder evolution started, in the modern era. And now we live in a global village, and in this global village, we know that everybody, no matter where you are in the world, is exposed to different influences. And so people, of course, take and choose different influences. So it has so one dimension is exposure to influences. The other dimension is the emotional distress. So the emotional distress can vary a lot from one person to another. So I tell people, when people say, I see you in my shoes, and I say, well, actually, you're not in my shoes, and I'm not in your shoes either, because everybody has very unique experience. So what affects one person doesn't mean it affects the same level to the other person. So if somebody has conflicts in childhood with the parents or with their siblings, they may react differently. One may react by becoming angry, upset, being very open, how they feel. Other person can be very introvert and can just try to control their eating at that time. And sometimes that habit turn into, or that practice turns into habit, and that habit turns into physical health consequences because you are either restricting or you are purging in form of vomiting or using laxative or over exercise. So there are different ways of one can handle distress. Um, so in different cultures, even within the uh, Islamic nations, so different societies, different cultures have different ways of reacting. Um, so, so when it comes down to differentiating what different kinds of eating disorders are, so in a nutshell, we primarily look at anorexia nervosa, which is about restricting and low body weight, bulimia nervosa, which is about binge or purging or both, um, and and then there is eating disorder not otherwise specified, where we see combination of scenarios. And then there is avoidant eating disorder or specific eating disorders, so where people are, especially children, they have strong likes or dislikes, or they end up chewing um, inappropriately, or they secrete the food that is given to them. So there are different ways, different kinds of eating disorders.
So, Dr. Sohail, why we don't have any mention of this illness in our literature, in Islamic literature, in Islamic medical journals? We can only maybe trace it back to one of the case studies in 1997 from Iraq, which was of a young male, and or maybe if we talk about Pakistan, maybe it could be traced back to 1990s. But if you go back to the 18th, 17th, 16th century, we have no mention of this illness.
Yes. So, mind you, we are a society where there is in some areas there is a suppression, and then some situations there is a lot of overprotection by the family. So that both scenarios do not help people raising their voice. And many times, another thing is to remember that many times is the parents actually drive when to take the children for help. So it's actually not the children or adolescents drive the treatment or drive the help or recovery. So in order for a society to identify disorder, any disorder I'm talking about, first they have to accept it. If you don't accept it, you're not going to identify. So similarly, I know that even in Pakistan, I give you an example. We see even children who are not talking at age 4, and the parents basically assume, no, he will start speaking, and we do know that the child at age 2 should be talking 2 words, and at age 3 should be talking 3 words in a sentence. But the parents are in denial. So it's in order for accepting a disorder or a pathology or an illness, you have to accept it. The lack of acceptance and the lack of participation in research, that they were the big barriers in not knowing, not this illness being identified in the Islamic world. We do, however, I mean, there was a research paper in Pakistan or a survey in Pakistan in a medical school, in a female med school some years ago, and that clearly showed high proportion of eating disorder than the general population. So there, you're very right. You're not going to see a large research papers or surveys in this area in the Islamic world. There are some studies in India also in this area, and there are some. I am sure there might be some studies in Indonesia, but I haven't come across recently on that.
Yes. So, Dr. Sohail, you've been in New Zealand.
Pardon?
Yes, you have experience, of working in United States of America, New Zealand, and Pakistan. So, are the rates of, eating disorders and views around eating disorders, different in different parts of the world? I mean, do you see a difference between, maybe there's a lack of understanding here with us? But what about New Zealand? And because it's very small in size, but there is a prevalence of eating disorders in New Zealand and America. So do you see the difference in the views and about the prevalence?
Yeah. So the prevalence-wise, it's very similar to US in terms of, so when you correct for the size of the population, the percentage-wise is very similar to US. However, we have a much larger proportion of Pacific Islanders, like people from Fiji and people from Pacific, other island nations. And in that group of people have a bit extra BMI is considered healthy. So their average BMI is 27, 28. That's their average. And so they do not consider, so culturally, they don't want to look thin. They literally don't want to. And they find a BMI of 28, 30 is much healthier. So from their perspective, so in that population, we see a lot of overeating, binge eating patterns. So that's the population we definitely see a lot more. In US, while we see a lot of obesity and binge eating, but those people, most of those people, they do not see that as healthy. They may see themselves as overweight, obese, and they may struggle in that area. But and they are into, in US, culturally, the portion sizes are very big. But in New Zealand, you don't have big portion sizes. However, in that Pacific Islanders, we find the use of carbohydrates, excessive use of food for various occasions. So in some ways, I see many times the Pacific Islanders use food for every occasion. When it comes down to whether it's the occasion of happiness or it's a sad occasion, the food is the primary thing in their culture, and we I think that's where we also see a relationship in our culture also. Mhm.
Okay, that's a really good answer, Dr. Sohail. So, Dr. Sohail, they say eating disorders, I mean, the reason they are very difficult to understand because they also coexist with, depression, OCD, PTSD, ADHD, personality disorders, and trauma-related disorders. So, how true is that? I mean, you're trying to explain to someone they have an eating disorder, and then to explain to the family that, maybe it's not just the eating disorder, there's also OCD and other related, psychiatric disorders happening alongside. But do you think this is true? There is a clear connection between all of this? Or the eating disorders can just exist on their own?
Yeah. So it's a very good question. I think, so I go back to some basic basic principles. So if somebody has diabetes, say for instance, and that person working on a stove and all of a sudden burn the finger. So all of a sudden now you have diabetes plus now you have a burnt finger. So one condition does not stop you from having another one or one condition or three conditions. So sometimes we can have two or three different conditions and we accept as human beings. Psychiatrically, when it comes down to psychiatric issues, sometimes people they really struggle understanding this concept. That sometimes we can have comorbid depression, anxiety. So yes, if somebody is not eating well, is restricting on food, clearly suffer from anorexia, and after significant period of starvation and anorexic spells or periods, that person start to have low energy and start to experience all the other depressive symptoms. That is in relation to eating disorder. But then we have patients who have adapted to eating disorder scenario quite well over the years. It could be bulimia or it could be binge eating disorder. But they can also still have depressive episodes, sometimes not really related to the condition. We do know that certain conditions exist more in certain groups of patients or certain types of patients. So, like for instance, if somebody coming from a family background where anxiety is very common, and there is a strong family history or genetic component of anxiety disorder, could be obsessive compulsive disorder, could be generalized anxiety disorder, could be panic disorder. And those patients, if they suffer from eating disorder, we need to treat both of them. If somebody we know very clearly suffers from depression secondary to eating disorder, we manage the eating disorder first. So, for instance, if somebody has anorexia and has developed depressive symptoms, we do know that number one thing that can help that patient is the right way of approaching around food. So once we fix the nutritional component, the depression component will take care of it. But sometimes, if somebody has a lot of purging behavior, where they're vomiting after binging episode, in those cases, we do know that on its own, sometimes antidepressants can be very helpful. Um, or so even if somebody doesn't suffer from depression, but if somebody suffers from depression or anxiety, antidepressants are much more useful in that group of clients.
So, Dr. Sohail, about the psychotropical drugs, is there a difference between what drugs you use, the medication you use to manage the bulimia and anorexia? Because with anorexia, when there is a low weight, you cannot really use the medication because of many reasons. But how effective is olezapine in managing bulimia?
So, yeah, can you see me?
Yes.
Yeah. So your question is around olanzapine, am I right?
Yes. And also, do you think there is a difference? Yes. When you come to manage the anorexia and bulimia, can they both be managed by one set of medication or no?
Mm-hmm. Okay. It's a very good question because so olanzapine came into. Let me first address the olanzapine issue. Okay. So olanzapine came or was brought into the market over 24, 25 years ago. So I was the researcher in the US at that time, and um, I, I was involved in phase 2 and phase 3 trials. So before it even went to the general public, that medication. So we started seeing very early on, it started causing weight gain. So before even it went to the general public or exposed, so and and at that time I was working also in the eating disorder unit, but we were not using eating disorder population for that. It was purely for people with schizophrenia and bipolar disorder. Primarily schizophrenia. We were using that. It's an antipsychotic medication. We definitely saw its role in anxiety. People who were getting less smaller doses, they were doing well. But at that time, we didn't know. It was a double-blind study, so we didn't know who was getting the medication, and we didn't know what dose of the treatment we were giving to the patient. Uh, so later on, when this medication got approved, we, we started giving it to even eating disorder. Oh, this is a great medication because it has one of its side effects is weight gain. So let's try in anorexia. This is I'm talking over 25 years ago. Okay, so very quickly we found out that actually we were adding more fear to the patient. So that was something we then started moving away from that practice because the clients or the patients weren't ready. You started giving a person who who is afraid of gaining weight a medication which pushes you towards gaining. So what was the reaction? The reaction many times was disengagement, or the patients would start doing over exercise much more. So or they were getting into much more purging behavior. So, we understood that this was not the right way to go in. So first of all, so that's why olanzapine never got an approval really for eating disorder, and then they started getting that feedback from a lot of practitioners that it's not going to work that well for that reason. But now going back to the medications that have been fully understood and tried and has worked. Fluoxetine or Prozac was the first SSRI, and it was also and still to this day we have the maximum data on that medication, and we found that it worked in primarily in two domains. One is it worked for people with bulimia, so it helps people regulate. Sorry, so it controls the purging behavior. Um, Also, so when you look at people at the frequency of purging, we found that the frequency of purging goes down. It doesn't mean it goes zero, but it's still. So somehow you start developing more satisfaction internally that you don't need to purge. And the good thing about fluoxetine is it's a long half-life drug. It can stay in your system for good few days, 24 to 48 hours without any issue, even longer. So even if you miss the dose every now and then, it doesn't really cause any problem.
So Dr. Sohail, I mean, just to make things clear, they should be taken under a strict supervision of a psychiatrist.
Absolutely. 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 I really I think this is a really, it's a really specialized area. So it's not only just a psychiatrist, but also someone who really have experience with eating disorder. Because like, I cannot speak for some of the other Islamic world, but I do know that in Pakistan it's very common for psychiatrists to prescribe olanzapine for anorexia patients, and we do know that it does not lead to a very positive outcome.
I absolutely agree with you. I second you on that, because I get people who are on these medication, and you ask, but why, what is the reason, who gave them that medication, and then, these some of the patients, they feel that, they can just go and get the medication and take it. But I would like to say, everyone, please, I mean, the medication we speak about here, this is only for the information reasons. So, if you want to get help, please, you have to be under a strict supervision of a trained psychiatrist who specializes in the field of eating disorders. You cannot be taking the medication randomly. So, Dr. Sohail, I want to ask you about the family dynamics in eating disordered people. Are there any relational patterns that stand out? Because you have, I mean, I'm specifically speaking about Pakistan here. So do you think there are common patterns between, the people who are suffering from eating disorders?
Yeah, yes, there are. And let me give you, first of all, we do know that in most of the time, a bit more affluent class. We see more of it than affluent class. But we also see normally eating disorder starts at a relatively early age, like 13, 14, 15, is the start. But we also see it's something different in compared to some of the other cultures, which is late onset eating disorder. It's very uncommon in the Western culture. Like in America, very rarely I found somebody who was above 50 and suffered from eating disorder. So who started the eating disorder after 50. So usually it starts early, but yes, I've seen people who are, who suffered with it, all the way from 17, 16 till they're 60. But there are people in Pakistan, there's some late onset. and many times it's more related to other relationship issues. Um, so we do in Pakistan society, it's usually quite a combined family unit. So sometimes you have uncles, aunties, uncles all in one place, uh, and and sometimes the girls find it hard, or the woman finds it hard to please everybody, and so that creates conflict. And and sometimes the way they compensate for is through their eating. Um, either as part of gaining some gratification or as part of hurting themselves. Um, so, so you see that, but in other times you find in affluent people who have the parents uh, who basically uh, not really supervising their children properly, the children on their own. Um, they uh, they have their own room. Um, they're not the parents not even supervising how that their sleeping periods. They are sleeping or staying up all night and grazing or overeating. Um, Getting food ordered in the middle of the night to their home, and binge eating or purging. Um, and then, and then also, some of them also have comorbid substance abuse. So they can be using hash or cannabis or repellent like products.
So, yeah, Dr. Sohail, do you think, I mean, I asked this question last time, but I'll rephrase it. A disturbed image of someone's body, do you think this is caused, or is it, like a symptom?
So I think it's a culturally driven phenomena. So it when I use the word culture, one needs to be very mindful of knowing that within one culture we can have 50 different cultures, because every household has their own microculture. So that microculture dictates the consequence also, how people going to evolve. So if a household you're coming from has a group of people who keep telling the children, you look fat, you look fat. So that would drive that an image of obesity as very, or even a slight overweight image will be considered very unhealthy in that household. And in another household, if the family is keep saying you are too thin, you are too thin, um, even that person and that kid is looking healthy, um, that would drive an image of a bit extra weight um, as considered to be a healthy or a healthy alternative. So, so I think it varies from culture to culture a lot. In Western civilization, if you look at it, then if you go back to movies of 70s and 80s, you would never see a very thin woman considered to be suitable for an actor. But but when you go into 90s, all of a sudden the beauty or the beauty had a different meaning, So, and we do know that the children and adolescents get influenced a lot with what they see. So for some, it it is through that where they develop. So it starts with the body images, and then it goes into eating disorder. And for some people, it starts with eating disorder and then moves into body images. Um, we do know that when you look at people who are very underweight, and if we do a survey of them, people who are very underweight due to anorexia or eating disorder, when you ask them how do they see themselves, they say, I always see myself as fat. But when you show them a picture of somebody else who is overweight, and you ask them, how do you see that person? And they say, oh, I see that person as normal. So it's a very they're very driven by their own image rather than so that's why when it comes to therapy, if I start saying, oh, look at another person, you are not so that comparison will never work in therapy. Because for that person, that image is her own image is very distant or satisfying.
Yes. So many questions, but we don't have much time. But I wanted to, before we move on to Ramadan, I wanted to ask you, this was one question which was asked. What do you think about a culture of perfect bride in Pakistan? Where women have become subject to, pre-wedding diets and, certain procedures, just, so they can look maybe good for a few hours, but the pressure and the torture they go through, do you think it's worth the pain to, put yourself, your psychological, your physical, your emotional health through that, just so you can look, good enough for certain clicks and certain pictures for a few hours?
So, when we talk about disorder, it has to have two components. That's really what one needs to understand. One component is that you have to have certain symptoms, right? But the other part is really important in psychiatry is you need to have a distorted level of functioning. So when we use the word functioning, that can mean occupational functioning, that can be distorted or that is compromised. It could be educational functioning. It could be social functioning. It could be your so if you are compromised at some level with these functioning in any of these areas, that you need help. One needs help. So say for instance somebody goes to these 5 or 6 procedures and all that, and at the end of the day it does not affect that person's functioning or enhance the person's functioning, then it's okay. I mean, it won't. I wouldn't call it a disorder because in psychiatry, it may have other issues, but it may be problematic to other people. But if it is not adding financial burden, if it is not adding the things, and it's not adding any unhealthy relationships and things like that. So then, but if it is starting to affect one's physical issues, starting to affect relationship issues, starting to affect psychiatric issues, like you're starting to become more obsessed, depressed, anxious, then something wrong. Then that way of approaching it is not going to work.
So, Dr. Sohail, because we don't have much time, there are so many questions, and we can go on and on and on. You're giving us such good answers, and we will be having answers on record, inshallah. So, let's go and move on to Ramadan, because we received a lot of questions about Ramadan.
Yep.
So, why do people struggle in Ramadan? Whether they are fasting or not fasting, people really struggle in the month of Ramadan.
So yeah, yes, you hit it. You hit it absolutely on the nail. Um, so whenever it comes down to starving for longer period, there is always a potential that you're going to overeat after that. There is always, especially when you have all the nice food items sitting in front of you. And then there are people around you who are showing the same practice. You do know when you do something together, good or bad, it reduces the level of guilt. So if you say, for instance, if somebody binges alone, that person may have a guilt of 70%. But if you are doing it together, it will reduce your guilt to 20%. So first of all, it's just so Ramadan, when you're breaking the fast, that what I'm doing is, even if it's overeating, that's the right thing because everybody is doing. So that's and also in Ramadan is one of those months where we, on a regular basis, you are sitting together as a family, as friends, or whatnot, especially around iftar. So that's uh, and these are the challenges we face when we have to when we deal with patients with eating disorder. And so we have different strategies that we utilize to help them under those circumstances.
I think, Dr. Sohail, it's the challenges are they vary and they differ from person to person because. But do you overall think, people who are suffering from eating disorders, I mean, it could be any eating disorder, we have so many of them. Do you think they should be fasting? That's one question you get all the time, or if you think they fast, they need to be under a strict supervision of a trained dietitian and psychiatrist. So, what do you think? I mean, because this is one question we get so much and there is no right answer right now.
So it depends on what stage of condition, what stage of the illness you are in. So or what type of condition you have. If you are in the early stages of recovery or early stages of treatment for anorexia nervosa, where you are restricting significantly, or early stages of bulimia, you need a peer support. You need true family support. You need very close supervision from from a professional when it comes to fasting or what you're eating. If you are in the middle stages of your recovery and you're not fully overcome the condition, but you have developed strategies how to overcome some of those barriers, then it's less supervision required. Sometimes even sharing your eating pattern, sharing the food diary with your professional is helpful, is good enough. But it depends on the stage of the recovery, where you are within your recovery. Because if I expect an anorexic patient to consume 1,200 calories during the iftar, it's going to be almost impossible. So in that case, you need healing supervision, you need support, you need to have rituals with that person so that person can help reduce the level of distress. and the right language for the family to use when uh, when encouraging that person.
So what do you recommend to, someone who is suffering right now and has been actively engaging in bulimic behaviors or anorexic behaviors, but the family feels, because they don't know about the illness, they think they should be fasting, but they simply cannot come around to fasting because those behaviors have become, self-fulfilling prophecy. They have become the ingrained part of their lives. Even simply thinking about not going without those behaviors is sending them into a panic mode. I mean, what is the recommendation for this person?
Yeah, so when we talk about the anorexia patient, uh, we, uh, before they even indulge in fasting, I would like them to develop a contract. Uh, the contract that is with their dietitian, the contract with their therapist, and the contract with their psychiatrist. And that contract, it's about give and take, and so if somebody is, we know that having a lot of fainting spells, we would say we won't encourage you to fast until your fainting spells are improved. You know, so once the fainting spells are less or gone, then we can look at the. Um, but if somebody is, and when we comes down to, and then we look at the food option, and then we also look at the cooking method, what that can work for that client, for that specific client. Same thing when we have clients with bulimia. Um, we would not encourage that person to have a full meal right at the time of iftar. So first, you need to have uh, water with have something like chia seeds, or but no smoothie, no nothing major, but just water with something, like mint or something. And then after that, we'll say you're going to do your prayer, have a break, and at the end, after the break, that's when the meal starts. And we help them to learn about mindfulness eating, because it's, and when we talk about mindfulness, it's about paying attention to every bite you are taking. So not concentrating on on everything that is in front of you, but really paying attention to every little detail. How it is swallowed, how it tastes, uh, uh, how much time you're going to take to finish it. So the mindfulness thinking combined with cooking method, combined with a pause uh, between the start of the iftar to finalizing your iftar, all these aspects play a big role in managing that person's behavior. And at the end, that person gain a lot more confidence about themselves.
Dr. Sohail, we are actually coming towards the end of the session, but we do have so many questions, but thank you so much for all the answers. Before you go, I just wanted you to say, do you have, please, could you give a message to everyone, to our government, and, people also who will be entering Ramadan this year who are suffering from eating disorders? So we would like to have closing remarks from you, please.
Yes. Well, I really think, one of the factors that we should be doing as a society is having less and less judgment about others. We need to have an open mind. We need to see, and I think if you have an open mind about your your siblings, your family members, your uncles and aunties, and if you start practice at that level, I think we're not going to start to develop more trust with each other, and that will also make us open to the idea of asking for help and support when we need it. In terms of idealizing things, I think in Islam, in our culture, there are a lot more other positive things that we can idealize rather than using some of those superficial images and superficial areas where you know they give you some gratification, but that gratification is most of the time it's short-lived.
Yes. So thank you for this, Dr. Sohail, and thank you for joining us. And I want to thank everyone who joined us. And so, inshallah, we wish you a very good stay in Pakistan. And thank you so much.
Thank you.
Again. Yes.
And I thank you for organizing this, and I hope people will find it beneficial.
Thank you. And we will be signing off. And I want to thank everyone, from Algeria and everywhere they have joined us. I know there's a time difference, but thank you so much for being with us. And thank you so much for sending in the questions and your support and good comments. And hopefully we will soon see you in a live session soon. Thank you so much. We are signing off. Goodbye.